Great, thanks, Chrissy. Afternoon, everyone. Hello. Thanks for inviting me to do this talk this afternoon. My name is Richard Croker. I am a pharmacist. I work 3 days a week as chief pharmacist for primary care at NHS Devon, ICB, and the other 2 days a week I am the clinical informatician team lead for the Bennett Institute for Applied Data Science at University of Oxford, and I mainly work on OpenPrescribing. I've been doing that for about over 10 years now since it first was released. So I'm going to talk today about what it is, how we use it, how we develop it. There's some relatively nerdy stuff at the end as well, talking about what we're planning to do for the future. So just to start off with the concept, primary care is the most, primary care prescribing is the most common intervention in the NHS. It's the second in health costs after staffing in the NHS. We've all had prescriptions. They used to be green bits of paper like the one on the screen. They're now more electronic. There were 1.26 billion of them dispensed in the last financial year, costing around about 11.2 billion pounds. It's a massive number. It's a ridiculous number. It works out at over 350 pounds per second that we spend in England, and it is only England, on the NHS. For me in Devon, that comes out at around about 237 million pounds and 29 million prescriptions being dispensed every year. So it's an awful lot of prescriptions, an awful lot of medicines going out, and it also produces an awful lot of data, and quite a useful byproduct of that processing, because every one of those prescriptions, be they electronic or via paper, go off to the PPA, now called the Business Services Authority, and they get processed so pharmacies can get paid for it. And as a result, we get really good, granular, accurate prescribing data. It's not really prescribing data, it's dispensing data, because if a patient doesn't take their prescription to the pharmacy, for example, to be dispensed, we don't see it. But it's a really, really great bit of data that we can then use to look at various prescribing patterns, trends and variation. It's been talked about for a long time. I've got a book on my desk here somewhere, I'm not sure where, called Social Aspects of Prescribing from 1957, where they were talking about the original the original Health Insurance Act of 1911, talking about an administrative machine to be set up in order to limit the drug bill, and that was still the case in 1957. 70 years later, it's still the case now. That's part of my job, is to look at prescribing costs in Devon. So we still do it. We still use the same sort of thing. These used to go out. One of my colleagues found these. They used to go out in the 1970s, hand typed up by somebody, making spreadsheets manually. And then it became computerized by the Business Services Authority a long time ago. And then it became a catalogue and all these sorts of things. So the data's been around for a long time and has been able to be used. And then in 2011, the then government decided that they were going to do a load of things around opening up data. And one of the things they did was they published practice level prescribing data for anyone to look at. And that's known as the English prescribing data set. And that's a data set that we use at OpenPrescribing. You can download it. Anybody can go and download it off their website. It's available every month. It's at practice level, so not as granular as perhaps we would like. There's no prescriber level data in there. That was felt to be too granular, but it gives us individual prescribing for every drug, every dose, every formulation, every quantity for each practice in England. It's pretty big. September 2025 was the last one I sort of looked at in terms of its data download. It was 7.6 gig. It was 18 million rows. We've ingested about 15 years worth of data into OpenPrescribing in our backend server. So that's an awful lot of rows, an awful lot of data to be wrangling. So it's not really one for Excel to be people to look at, although people do try. That's what the raw data looks like. It's just practice, drug code, drug name, strength, quantity, etc., and how much we paid for it. But as we talked about before, what it's got there is total quantity and how much it cost. And the latest version that's now been made available also has SNOMED DM&D codes, which gives us better granularity in some things. For most things, it doesn't change. but for some things there was, I think, the old coding system, which is BNF code, which we still use, had one code, and there was 181 different DMD codes listed against it, and that was some odd thing around tattoo colorings or something. But getting better granularity, it allows us to work more with the DMD, and we can talk about that later during Q&A if people want to do. Okay, so in 2016 we relaunched OpenPrescribing, which is a tool. It's a tool to use to turn all of that data into actionable insights for people like me, as a pharmacist working for the NHS, people like doctors working for the NHS, and practice teams working in practices for acute trusts, local authorities, patients, drug companies. Everybody and anybody can use it, and everybody does use it. It produces a load of tools so that we take away all the hard work and just give people the actual insight. And I'm going to go through some of those today. This is what the front of the website looks like at the moment. This is a breakdown for a practice in Oxford. It gives you ideas on measures and the NHS low priority measures. There's things about price concessions, which I'll talk about, how you can save money for the NHS, and the ability to sign up for alerts or updates as well. Just one thing on this. This is GP data, so we don't tend to have any out of hours data or anything like that. It tends to be just prescribing data, and one of the reasons for that is how we build measures and how we use effective denominators. And if you can't use an effective denominator, which is really hard for a thing like an out-of-hours service, it's very difficult to build that. It's okay to compare X drug versus Y drug, but as soon as you start getting into population denominators, that starts getting really hard. So for now, we've removed all that sort of data. So this is the 6,500 primary care GP practices in England at the moment. So this is Devon data. Gives us tools for actual insights, whether that's patient safety. So the one on the left there is about hypnotics and anxiolytics that we have real problems with in Devon in terms of prescribing. We can see it's coming down, but we can see in terms of deciles, and we measure things tend to be in deciles, that actually we're still one of the highest ICBs in the country and have remained that way. In terms of cost effectiveness, this one is about most cost-effective use of drugs. So I've just seen a message. Are people hearing me okay? Is that okay? Must be just Chrissy. Okay. Then thanks, Chrissy. Thank you. So in terms of this drug that is £1 or £2 a month versus something that's £40 a month, NHS England asked us to change everyone to one of them about 3 years ago, and then asked us to change everyone back about a year ago. So you can see how we're doing against that. Thank you, everyone. We also have sustainability measures. We look at carbon dioxide impact of ventilator inhalers, for example. And we also build measures on the efficacy of drugs. So vitamin B complex, which is often used in alcoholism, doesn't have enough thiamine in it to be really, really effective. There's other things you should be using, and actually you should stop using it where possible. And you can see that we did a piece of work about 5 years ago that really had an impact. But we don't just build measures and just leave it at that. We also have some sort of really good data science insights under the bonnet that allows us to do various things. So we have sort of a change detection tool, which I can't quite remember where it came from, but it was something around climate change work originally that was adapted as a QSUM process for us, and that identifies where practices have changed. And either good or bad, and then we can send out emails every month, and we do, to any practice PCN or ICB that subscribes to them and says, compared to everyone else, we found that you've done a good thing here, or that you seem to have gone a bit awry on something. So this is an email that came out to us a while ago that will say, this is picking up that we're getting worse. We had the original email in Devon saying, wow, you've done something quite good. And now it's saying that we've slipped because everything else is getting better, and we are slowly drifting away from that again. And that's to do with the data science techniques that we use in order to do the work that we do. It's time. We also, we're a university, we do a lot of research using the data as well. And so, for example, we did some interactive time series analyses on whether or not the chief medical officer writing out antibiotics to tell people to stop using antibiotics had an effect. As you can see there, it did, which is good. We also did research on urinary tract infections and how practices and ICBs made a change and what was effective and what wasn't. And we could see, for example, these here are some Nottingham-based ICB or CCGs at the time, and they had really clear guidance for practices. They paid practices to do stuff, and that really led to a massive change in their prescribing almost immediately. Whereas practices that didn't, and you can't quite see it there, but West Norfolk didn't do that, their change wasn't so good. We find some really interesting, weird stuff, and this is a paper we wrote a few years ago using data-driven identification of unusual prescribing behaviour. So this is a drug called paracimazine, and using information that the data that we had looked to see what was going on. So this drug in Norfolk is about 1 in 5, 1 in 6 antipsychotics are prescribed paracimazine, and it's the only place in the country where it happens. The rest of the country basically prescribe none of it, and we have never been able to find out why. We've asked various mental health departments, pharmacists, doctors, whoever you speak to in Norfolk, why they use this drug that has just a few mentions in PubMed as opposed to several tens of thousands for things like quetiapine or olanzapine, and we've never been able to get a satisfactory answer. But still, legacy is that years and years and years after this started, this is still a massive outlier. We found some other things around some other drugs in the country, and we wrote about them, but we were able to do that because we've got this massive resource and stability to it. We found there were problems with GP computer systems. So System 1 had a thing that allowed GPs to prescribe expensive drugs inadvertently. And we wrote about it, we wrote a blog about it, we wrote a paper about it. System 1 very kindly got in touch and said, oh, that's interesting, tell us all about it. And that problem by this point was starting to grow very rapidly, and just a few months later had gone away. So this is sort of work that we can do with that open source data, with the data science techniques that we use. There's another one we've talked about, that cumulative sum technology to identify outliers. I don't need to talk about that again. But we're not the only people that use that data through OpenPrescribing. There have been lots of papers as well by other researchers that use our data to find interesting things out about trends and variations and changes in prescribing behaviour across the country. As I said earlier, we already send an email out. There's another one that we had saying we're getting worse in antibiotics. We've got lots of other tools as well. So we build these measures, these actionable insights, that we've got about 78 of them at the moment that describe the cost effectiveness and the efficacy, but we've got a lot of other tools as well. One of my favorites is the price per unit tool. So in England, sometimes, and increasingly so, there are problems with various availability of drugs. And we in the NHS find it really difficult because, for example, it's the 23rd of February today. We don't yet know what the price is of some of the drugs that we are buying in February from community pharmacies. And it creates a real problem for us because it might be a lot, it might be not very much at all. So how we work that out is quite important. The other thing there is there's real variation around price per unit. So one drug might cost £10, £15, £20 a month. And a very similar brand or a tablet rather than a capsule might cost £1, £2. And it's very difficult in our job to find out what's going on to try and find the best value for money in those medicines. We have built a tool that does that and provides the same actionable insights for anybody who uses it, practice level, PCN or ICB. So we can see here that for me in Devon, the most top saving opportunity is a drug called venlafaxine capsules. And if we were to click on it, you can see it shows you a really useful graph as to how much we're spending, which is the size of the circle, and what its cost per capsule or tablet is. So we can see here that people are prescribing it generically, I think that probably is I can't see that because it's too small, are paying 6p a capsule, whereas certain brands or a tablet rather than a capsule is a third of the price. And if I just go back a step, we calculate how much that saves. So we think that would save us £63,000 a month in Devon if we were to switch to the cheapest one. They're not all real, they're not all achievable, but it does give us an idea of some things to look at when we're trying to work out how to save some of that £237 million that we spend every year. Price concessions is the thing I was talking about earlier. So this is the bit where we don't know what it's costing us. It's a real problem and actually costs a lot. So this is the national, this is the Devon one, and we can see that a couple of years ago, so I think this is December 2022, the additional cost of drugs that we have to pay for because they've gone out of stock was over £1 million. And that was on something where we were spending about 16-17 million pounds a year. Huge amount of money. And I was really surprised when we started looking at this a few years ago that no one in the NHS was doing this calculation. We think that in about 2018, when it reached its peak, it was costing NHS an additional £250 million over a 6-month period, which, interesting enough, was exactly the same amount of money that Theresa May, the then Prime Minister, had promised as additional funding for the NHS. It was all swallowed up with expensive drugs. But nobody was doing it. And so we built a tool and thought, how can we just show people, give them an idea, a bit of an alert on how to do it. So we built the price concessions tool. It gives you a real list. So amazingly enough, as of November for Devon, the most expensive thing that we can't get is aspirin tablets. They are out of stock. They're expensive. They currently cost, should normally cost £20,000 a year. They're currently costing us an additional nearly £100,000, sorry, a month, £100,000 a month for aspirin tablets. Having that information is really helpful to me as a user. And it's a really simple tool to build, but nobody done it, so we went and we built it. And we get an email every time it comes out. We get an email to say, here's what your updated price concessions costs look like. And I suppose my favorite bit, actually, of OpenPrescribing, all of it, is this. This is our Slack channel. So we use Slack rather than Teams at the Bennett Institute. And it allows integration with our servers and all of our coding. And we use it to run things where we want to do. So every time I get an email saying that the price per unit, the price concession data has been updated, I just need to give our Slack channel 3 commands. BennettBot is the name of our bot. We ask them to go away and import it. It goes away, looks at the website, and scrapes and codifies all of that stuff that's on the Community Pharmacy England website. It does that in a few seconds. I ask it then to report to me whether or not it's got any problems. It hasn't, and I give it another report that says, please send the email sent, please. So I did that at 17:08 the other day, and by 17:10, I think it is on here, it sent me a bespoke email with all of its all of the things just for NHS Devon. And we have several hundred people who have signed up to that, and we find that really useful. And we find that our user feedback is really helpful, and that our ability to do stuff like that really helps our users. One thing we do, OpenPrescribing, Bennett Institute for Applied Data Science is a very open-facing team. Obviously, I'm sure most of you read the Goldacre review. He talks about open methods of working. He is our director at the Bennett Institute. Everything is on GitHub. Everything is open on GitHub. Everything can be seen. All of our thoughts around why something's broken, which I can talk about slightly in a minute, how we're going to fix it. All of our code is there. All of our definitions are there. And I found that quite different when I started working there compared to the NHS. I think there's still a culture in the NHS of everyone hiding behind the work that they're doing, and some of our the data sources that we have, it's very difficult to find a definition on what we've considered to be in and out for a numerator and a denominator. For anybody can go and look at it, and everyone can go and see it. So, for example, this, you can't see that, I'll come on to it in a minute. This is the back end of one of our measures, which is about opioids, and how do we write what we consider to be a high dose opioid and not. That's a zoom in a little bit better if you can see it. But basically, we use various parts of the DMD to build it, and then we declare various things if we want to exclude them or include them. Personally, we're moving away from this, which is great because I don't like the JSON, but it allows us at the moment to be really clear when we write something, what we're doing, and we write it at once, and it then spits it out for everything every month. There's no need for any manual work for any to do it. And then we're trying to move away as well from manually creating drugs. So we're trying to build much more of a concept-based thing around drugs using the DMD. So if it is, for example, it's simvastatin, and it's a tablet, and it's got a unit dose of greater than 20 milligrams, for example, then that will be included, and that then stops. Sorry, I said if a tablet. Then if you say if it's oral, that then stops if a capsule comes out, it not being in there. So we find that the accuracy of our work is improving by moving to much more of a concept-based programming. We also have some really clear things on analytic choices. So this is, I think, I would say this is a measure on antibiotics. So firstly, always label your graphs. But this is where we had an issue where penicillin went out of stock because of a respiratory outbreak in children back in December 22. And you can see it really clearly if you use 1 month data. And if you use rolling 12-month data, which a lot of prescribing data sets tend to use, it disappears entirely. So there's an awful lot of debate often about what sort of data we use, how we do smoothing and all those sorts of things. And those conversations are ongoing. And then we tend to write blogs about it. For example, this one was a really key one to write about our analytic choice as to why we're using monthly rather than 12 monthly. We haven't had it for a while, but people can come along and write things in our GitHub if they want to and ask us questions about what they want to do. You can also drop us an email. So it's a very whistle-stop tour about what we do and what we build. We're quite successful. So in the last 12 months, we've had 367,000 unique views, unique visitors, and about 1.8 million total page views, which, when you think about, it's quite a niche subject, prescribing data in the NHS in England, we're really, really happy with. What I would say is there's been quite an increase in the last few months, which is great. We have had a bit of an issue with LLM bots in the last few weeks pulling our site down. So we've had to put some different things in place. There's one called Super Bot Fight or something in Cloudflare, which stops some of the bots at source, and we've had to put checkers in on non-UK based IP addresses. But that's all new, and it seems to have been stable. But it's one of the reasons I'm not doing a live demonstration very much today, because if I was to do a live demonstration, I know damn well that it would be exactly the moment that we're getting attacked. So it's open source data. And you've got to be really thoughtful in the use as a result. So we know in the English prescribing data set, we know what's been prescribed, and we know how much it costs, but we don't know who it was for, and we don't know what it was for. And therefore, we don't tend to put massive things out there about what does good look like. Because we don't have any population data specifically for the drugs in this data source. All that we have is that somebody has got it at this practice. It's a limitation, but it's fine as long as we just really clear what we can use it for and what we can't use it for. So example is that pyrazine I talked about earlier. You know, that's great. What does good look like? This might be the greatest drug in the world. Are these people actually just, is there a specialist centre in the middle of Norfolk that's doing these sorts of things? No, what is the reason? There's variation there. It's clearly difference there, but we don't know whether or not they're good or bad. And also, I think we might have had a question about this, which we'll come on to in a minute. How do we compare? I've talked earlier about denominators and you know, not being able to do out of hours services, for example. So do you compare drug A versus drug A and drug B? We tend to always write our measures so that low is always good, which sometimes requires us to turn ourselves in knots a little bit. Do we use a population thing like a list size? Do we have a specific denominator like a prescribing unit, which is 40 years old? Like an Astro PU, which you hear bouncing around. They haven't been updated for 15 years nearly. They only had an R-squared value of about 25% anyway, and they were only for whole practice population spreads, not individual items. Lots of my medicines optimization colleagues love to use them for individual bits. Please don't, because they're not right. There was also the star PU, so looking at specific indexes and all those, but actually they haven't been updated for 15 years either, and the clinical landscape of drugs and treatments is very different from 20. I can hear my headset going, so I may have knocked out there for a second or so. So how do we do that? And these are the things about being thoughtful in the use of this open source data where we are limited as to its understanding. As I say, it's not a bad thing. It's just we need to be aware that it's a limitation. So we built OpenPrescribing. We just celebrated its 10th birthday. It's now quite old. We're planning on having quite a bit of a rebuild in around about 2020, but something got in the way. And one of the things that got in the way during that was the development of OpenSafely. So for those who don't know, it allows us to do research on the entire UK or England primary care health record. That was built in a few weeks for us to do some work on vaccines and things like that. It's now, I think, gone live yesterday for non-COVID use. I'm not here today, and I think we may well get somebody in to talk about that in the future. But as a result, OpenPrescribing has been a little bit out of our minds in terms of funding. Funding is quite difficult to get hold of for things like this as well. But we have now got some funding for the rest of the year, and we are going to build OpenPrescribing betas. What does that mean? I'm just going to share my screen to give you an idea of the sort of things that we're talking about. Hopefully you can see that. So one of the things we've done, not very much on at the moment, but we're hoping to, is forecasting methodologies for drug spend, which, as I say, £11.2 billion, an awful lot of money. So this is a Jupyter notebook. This is how we've been planning on stuff. I don't plan, by the way, on describing much of this, except to say that we're using BigQuery, which is Google's sort of cloud-based machine learning tool. That's where a lot of our data sits, to do ARIMA forecasting, and I found it to be incredible. So we can fire queries at this. It will do forecasting, ARIMA forecasting based on 3,500 different drugs, and it will forecast them all going forward by the rest of the financial year in about 15 seconds. When I was trying to do it locally on my own desktop, it was taking half an hour to do 10% of that. So amazing tools to be able to use. It's incredibly speedy. And actually, just looking at this is looking at forecasting forward to the end of the financial year, last financial year, because it's currently testing, about forecasting what drugs are used, and then we can retrofit drug prices back onto them to give us a more accurate level of forecasting. So that is very still in its development stages. We're also using Streamlit. I don't know if, I'm sure people have come across Streamlit, but it's really helpful for prototyping these sort of open source tools. So this is one that I built the other day. It uses DuckDB in the background, which I'll come on to very shortly. And this is just looking about using opioids in primary care, and exactly how much of each opioid was used using a particular type of measurement called an oral morphine equivalent. So the weaker the opioid, the lower the oral morphine equivalent is. And it's just a donut graph, right? But the thing for me is using millions and millions of rows, but it is the speed by which DuckDB will then just cut that down. So if I go down to practice near me, I'm in North Devon today, it's, what's that, a tenth of a second? It's calculating those percentages and then calculating things beneath it. And so I find that incredible. DuckDB seems to be really good, very, very quick open source tool for doing database for exactly the sort of thing that we want to do. So this is just another one. This isn't quite so interesting, but it calculates difference in prices. These are the sort of visualizations that we can now build very quickly using Streamlit to just see whether things work, which we've never been able to do before. And then finally, very finally, we are rebuilding OpenPrescribing from the ground up, and we are using DuckDB as its interface as its back end. And just to give you an idea, so one of the things we've talked about for 10 years is the ability to calculate deciles on demand. So all of our measures use deciles, but they do take up an awful lot of processing time, because they are, you have to calculate everybody's things and then work out where they are. But you can now do this sort of thing. So here's one of our measures, which is apixaban and rivaroxaban. So sorry, it's boring, but it's quite clear. And this is, of course, where it's not going to work, is it? So we select our apixaban. Let's just go for that. Oh, no, let's go for rivaroxaban as well. We select all of our different drugs. I'm just going straight for the capsules there. Okay. And we'll do that by the 4 drugs that are in that group, which are those 4. We only want generic for those ones I've just selected. I work in Devon. Let's see how Devon's doing. And then click on submit. And it's not going to work because it's a beta, and it's not going to work. So let's just pick let's just pick something else. I'm going to just pick some things at random. There we go. Oh no, that's a terrible one to pick at random. We haven't released this yet, obviously. 0103. Right. So let's go for proton pump, all proton pump inhibitors. Nothing like a live demonstration. Right, there you go. That's better. Against everything in the cardiovascular system. Remember to hold down Control, Richard, and it will then work. So that hasn't worked at all, has it? Isn't that brilliant? Right, let's have one more go. This is why it's booted. We only built this last week. Let's go back to the oral anticoagulants. Let's go for apixaban tablets. Take those away. Thank you very much. Against those 4. Let's not worry about putting. Oh, there we go. Straight away, it comes in. So the deciles on demand are incredibly quick, and now it's not working again. I'm just going to give up. Right. Okay. And on that glorious end, that's OpenPrescribing for you. Thank you very much.